A warm good afternoon to one and all present here. I welcome Dean Sir, Dr. Satish Kose, Vice Principal Ma'am, Students Affair, Dr. Padmavati Ma'am, speakers, the organizing committee, and the participants. For our sixth module of National Faculty Development Program on Wellbeing and Salutogenesis of University Students. All our sessions on FTP will be streamed in the YouTube, and the link for our last session has been shared in our WhatsApp group. The last session was on mental health problems and substance use disorders among university students. The topic for today's presentation is about early detection of impaired health and well-being among students. This session will be shared by two speakers. Our first speaker for the session will be Dr. Avdiyappan sir. Sir has done his MBBS from Perendurai Medical College, MD Psychiatry from Tanjavur Medical College, has been practicing as a psychiatrist since 2012. Sir has been working in Mahatma Gandhi Medical College since 2013, has joined as an assistant professor and has been promoted as associate professor since 2019. Sir was in charge of the transgender clinic from 2014 to 2022. Sir has a private clinic in Kadalur, Manam Thirandu Manalala Marutvamayam. Sir has been actively involved in community and outreach mental health activities as a guest speaker, panelist, resource person, especially in government national mental health programs. Sir is interested in public speaking and awareness creation about mental health. He's also interested in writing novels and stories. Today, Sir's topic is about the challenges in early diagnosis and treatment. We welcome you, sir.
Good afternoon to you all. I thank you one and all for again joining us this afternoon. And this session, I'm trying to play the devil's advocate, and I'll open this session with the very negative outlook of things, like about the challenges in the early detection and treatment of mental health problems. So we have a pandemic of metabolic disorders in our world, but we don't do screening for these disorders in students and when they join the college or when they join we are not trying to make it like a priority thing for other. Then why do we need a priority for mental health issues or mental health problems? Because the one thing is we have a huge amount of issues which are actually not recognized. So these unrecognized or unidentified burden is causing a huge havoc in the youth, and especially as this is a developmental period, this having a mental illness in this period makes a huge effect on the future course and the recovery of the mental illness. Also, in the natural course of illness, most of the illness start in the very the first and the second decade of life, like when the second and third decade of life, like in the 10 to 20 and 20 to 30. So most of this, the onset lies in those decades. So picking them up early is done during this period is a very important thing. Why? Because when there is a delay in the treatment, that leads on to a lot of resistance to the treatment, accumulation of morbidities, and then a lot of other issues, and then there is a poor quality of life, a lot of other issues, host of other issues comes in. So that is why we need to identify them early, and we need to identify and detect them early and do that. And colleges and schools are best places to identify these early problems. So but these are not without any issues. There are a lot of challenges in the early detection of the health, mental health issues. So the very first thing we will talk about is reliability and validity of the early detection. There are challenges in measurement. There are challenges with the follow-up on detection. Also, there are challenges with the follow-up, and there are problems of confidentiality, and then there are problem of stigma. So the first thing, we'll take it one by one, and the first thing is reliability and validity of early detection. See, the question we need to think here is what is mental illness, and how is it different from a normal course of development or normal mental health issues. See, every one of us, when most of the time, when I have patients in my chamber, the attendants who are accompanying the patient, the very first thing they say is, sir, yeah, you also have so many issues. I'm managing the issue. So why not this guy is managing the issue? This is not a thing to get worried. No. So they tend to say that they tend to think of any illness, mental illness, as a natural reaction to the normal events, or tend to normalize things. So this is actually wrong. We have to realize that mental health symptoms are some things, symptoms of mental illness are something which are not a normal part of it, but they do overlap with normalcy. In that sense, we all feel happy, but when we feel an extreme of happiness, and we feel when we lose the control over our happiness, then it becomes an issue. When we all feel sad, but when we go to the extreme of sadness, when we become so depressed, then that becomes an issue. So that point where that's overlap of between normality ends and abnormality begins is a huge debatable things, and that is one of the issue in identifying the illness, early identification. Because when we pick up something, we need to know whether this is a normal variant or is it an abnormal thing, and how, if it is a normal variant, how far within normality is it, or if it is an abnormal thing, how much are we confident about is it being abnormal. So those are the questions which comes up it. And this is complicated by the fact that there is a subjective nature of diagnosis in mental health. Most of the mental health diagnosis are made by the individual. There is no laboratory measure, there is no definite laboratory finding which can be given for a mental illness. If I am saying I am a diabetic, then I definitely have a blood glucose level to show that I am diabetic. If it is not there, then it is okay. But if I am saying I am depressed, what is the measure I have to show that I am depressed? What is the measure to show that I am having a psychosis? There is nothing in it. So that is again complicating the problem of early detection. Also, when it comes to the validity of the early detection, it relies not on the information provided by the individual. Most often, they might not give the accurate information, possibly out of stigma, possibly out of misinformation, possibly out of simple boredom. When you give a bunch of questionnaire to a student, and then those students who are in the early teen, in the late teens, they don't have that. They don't have that thing to stay in that and answer that. They don't take it seriously. They just mark it. Sometimes we have found that the questionnaires which we distribute, they mark randomly, like 143, 143, 143. So that shows very clearly that they have not read the question at all, and they are just going to so that defeats the entire purpose of screening and students. So that again is an issue in early detection. So something which we get out of this questionnaire or anything, then finally what happens is the validity of the data is the question. So how can we can say we cannot go behind 500 students taking up all the questionnaires and be checking again and again whether they have reliably rated this, and then we do that. When based on that we come to a conclusion, that becomes a huge issue. So that is another issue with early detection. And there is again, when we are at the measurement, there are challenges with the standardized measurement. The problem is there is no single standardized tool for measuring mental illness or detecting mental illness. See, again, there's another question which is coming up. When we are going to screen for what are we going to do? In the screen in the youth for mental issues, what are we going to do? Are we going to detect illness, or are we going to detect factors which these people have, vulnerabilities which these people have, which can predispose to illness? Or are we going to screen for their protective factors which they have against the illness? There are so many things we can do with this. So what are we going to do? How are we going to design the questionnaire? And if at all we are going to do everything, then the questionnaire becomes so huge, and then it is not possible for a person to answer those questions. And another thing is the questionnaires which we choose, most of them were devised by the foreign, the Western authors. So how reliable are they in our setting? Are they linguistically validated? Are they culturally validated? All those questions comes in. Like, for example, a very simple thing is, suppose I feel there is even I feel down. I feel down most of the time. There is one questionnaire which rates this item. How do we linguistically validate this? If I translate it directly in Tamil, then that is no meaning. That carries no meaning. And if I do validate it, if I use எனக்கு எப்போதும் சோகமா இருக்கு, nobody understands that. And they say that எனக்கு சோகமால இல்ல, எனக்கு கஷ்டமா தானே இருக்கு. Then they mark it as different. No, then all these things, whatever the question which we gives up, and all these things should be validated properly. That is again not that's again a huge issue. We don't have an culturally or linguistically validated questionnaire. And again, once we have a questionnaire, we need to ask properties, the questionnaires properties, whether it is detecting that properly, whether it is what we are doing it as once we have adapted it culturally. So again, that takes a lot of time. We need an thing to validate and measure. So if you see, there is no universal single questionnaire which can do all these things. So that we need to, again, is an issue here. Finally, again, that coming to the length of the instrument, if we include so many things, the instrument becomes so long and so tedious, nobody is going to answer those questions. So then, okay, somehow we have surmounted this. We have got an instrument, we are using it to measure, and we are that's a reliable, valid thing. And then we comes the issue with the follow-up. I have found out few people who are at the risk of the health issues, mental health issues, and I have asked them to come for follow-up. This is, first of all, we need to know that for the very first step we are doing here is screening. For any big group to detect an illness, first we need to do a screening. So the screening measures are not sensitive enough, are not specific enough to pick up the issues. They are sensitive, they can detect any changes, but they are not specific. They cannot tell this is the issue. So that need to be done only by face-to-face interviews. So when we call them for face-to-face interview, they may not turn up. What do we have to force them to come to the place? What do we have to make them accept the counseling? And then once they come up, if they ask, we give them some diagnosis, they may not accept the diagnosis. They might say that this is normal, or this is something which I can deal by my own, and you are pathologizing my problems. So that again is another issue. Or they may not accept the treatment. If we can ask them, this for this you might need to counseling, or you might need something, medications or anything, they may not accept it. Finally, there again, if at all they want to come, if they want to come for treatment, if they want to come for another thing, then there is a thing. See, they have come here to study. Their schedule is packed for that. That's jam-packed from morning 8 till 4. They will be doing all their classes and other thing. Where they have time to come to a psychiatric counseling or a psychologist counseling, where they have time to visit that. So all that becomes an issue. So that again makes the follow-up suffer. And then there is an issue of parental pressure. Parents will not not accept the diagnosis unless until it is very much evident. So until the crisis comes, if you find an early problem and tell that, say, this is a depression, or this individual is prone for depression, he might go into this, so we need to interfere early, or all those things, parent might object. They might say that you are pathologizing my kid. How can you say that my kid has mental health issue? That is not acceptable. So that again, they put a pressure on the kids. They don't want them to come for follow-up. You just sit in a room, don't go for a counseling. So that those things happen. So there again, the issue of follow-up, all these things suffers. Then finally, we have confidentiality. That is another most important issue with this. There was one student whom I saw outside. Is from another college. She had the depression. So when she came to my clinic, I asked, see, you are from a medical college. You have the fully functioning psychiatric unit there. Why don't you go there? She said, sir, I was earlier going there, but my visiting to that psychiatric clinic, psychiatric OPD was raising a lot of eyebrows. People were talking about it. People are asking why she's always going to psychiatry. Is there some issue for her? Is she having some problem? And they are trying to portray it in such a way that I am having some big issue, something which is uncurable, another thing. So all that is that tongue wagging brings a lot of pressure into the kids, and they don't try to come to that. And again, there is when need to share the information given by the students with the administration as well as with the parents, which most of the students don't like. The very first thing they come to us counseling, the first thing they want is this information which I am giving you. Please don't involve my parents. If you are involving my parents, I don't want to come here. I don't want to. Suppose they are giving us a hint of suicidal thought or suicidal death wishes. Then obviously we are in a we have to inform the family members, or we have to inform persons who are in the immediate vicinity, and we need to take a proper admin needs to be involved. So because there is a high risk case, student for suicidal, those who are expressing suicidal tendency, we cannot deal with offhand manner. But then what about confidentiality? Once we lose the confidentiality, then the kid might not come back to us. So screening the individual doesn't end with that. We have to ensure confidentiality. Next comes another thing is the need to disclose the information to the supervisors. There is actual no direct need to disclose the information to the supervisors. Supervisors, by which I mean the individual is coming to here the college, so there might be multiple departments. The departmental HODs might be involved. So they might have taken leave. They might have classes. They might have to take a break from the class to attend the counseling session. So all those things are there. So we need to tell the supervisors, their HODs or their assistant professors, that there is a need for this. Suppose if those supervisors are now having a very negative attitude towards mental illness, then what happens? They will not, they will try to, we have had cases where they have actively tried to stop them from coming to counseling. Why are you going to counseling? Are you mad? Are you having an issue? Why are you going there? Don't go there. Those people will make you an idiot. They will give you medication. They will make you sleep, and they will not let you do anything. We have had all these words from our own brethren. So I don't think that's an easy issue to solve. That again needs to be looked into it. We need to say how we are going to deal with those individuals. And then we have a stigma. That is a very important thing. We have 4 kinds of stigma. One is perceived stigma. So when an individual is diagnosed with a mental illness, the very first thing is they're feeling themselves stigmatized. They look at other people, their way they are interacting with me, they're belittling me. Either you show empathy and sympathy and concern, then they take it as why. That is because because if I have a mental illness, they are showing me too much of concern. They are trying to patronize me. And then if they are like being neglected or doing because I have mental illness, they are acting differently to me. So this sort of things are like perceived stigma. They feel that change within themselves because of the mental health diagnosis. And then there is a self stigma. Most often, the very first thing the individual enters into our chamber, the very first thing they tell is, உங்ககிட்ட எல்லாம் போய் நாங்க வந்து ட்ரீட்மெண்ட் எடுக்கணும்ன்ற நிலைமைக்கு என் லைஃப் ஆயிடுச்சு சார்ன்பாங்க. So I don't think they will utter this word into a neurologist or to a cardiologist or to an endocrinologist or to any. only to psychiatrist உங்ககிட்ட எல்லாம் வந்து ட்ரீட்மெண்ட் ஒன்று இங்கே கொண்டாந்து எனக்கு லைஃப் நிறுத்திடுச்சேன்பாங்க. ஸோ தட் இஸ் த செல்ஃப் ஸ்டிக்மா தட் ஐ ஆம் பீங் டயக்னோஸ்ட் வித் mental illness. I am so pathetic. My life is ruined. So that again puts a lot of issue with here. And then there is a public stigma. The stigma, real stigma that exists in the public, which people, when they see a person diagnosed with a mental illness, they start to treat them differently. They start to do the things again different manner. So that again puts a lot of pressure here. And finally, the institutional stigma. The institute as a whole should normalize or should treat the people with mental health issues in a normal manner. If they are not doing that, then again what happens is the individuals tend to have a lot of issues with the issues getting treatment and getting for help for this. So all these issues are the challenges we face in early detection of mental illness. So to surmount this, how are we going to do would be the next part of our FDP, which will be done by Sarkar sir. Thank you for your listening. Thank you.
Thank you for the nice presentation, sir. Next, we will have a session on early detection and treatment and how to handle it. This session will be shared by Dr. Sukanto Sarkar. Sir has done his DPM and MD psychiatry. Dr. Sukanto Sarkar has done his DPM and MD Psychiatry from Central Institute of Psychiatry, Ranchi. He was a former professor of psychiatry at MGM CRI and is currently heading the department at All Indian Institute of Medical Sciences, Kalyani, West Bengal. Sir is a gold medalist in postgraduate diploma in health professional education from SPV in 2017. Sir has had over 35 publications, both in national and international peer-reviewed journals, along with one book chapter under Elsewhere publication. Sir has received various research grants and won awards for scientific presentations at regional and national levels. The session will be we welcome you, sir. Over to you.
Dr. Sarkar, sir, yes, you can start your session.
So shall I share my screen?
Yes.
But it's showing disabled.
Yeah, you can share your screen, sir.
Are you able to see it?
Yes, sir.
Okay. Right. Is it moving now?
Yes, sir.
Right. So at the outset, I'd like to thank the team headed by Professor Shibra Prakash and very nicely conducted by Dr. Vimal and the teammates. I think this is a very appropriate topic that we are discussing over the last few weeks. And the way Audapan has started this session, there are a lot of challenges that he has shown to me and to others also, like why we are doing all these things then. So we'll start and we'll try to answer his some of the queries. Definitely some points are very pertinent and we cannot do anything about that. So my topic will be early detection of impaired health and mental well-being among students. Right. So the outline of this talk will be the various methods that we use to early detect the problems is psychological assessment, the entry level, various awareness programs related to stigma, symptoms of impaired mental health, health promotions, etc. The mentor-mentee system, the peer group program, teacher as a mentor, student counselor, student salvage agencies or welfare committee, student club or student houses, and team psychiatry at the end. So before we start, I'll try to answer one or few questions. Audappan is still there, I think, of Dr. Audappan. When we do this kind of health screening, definitely what we know through ages, when I was doing my medical, this at the entry level of MBBS, I'm talking about MBBS, I'm not aware of the other courses. There used to be a medical examination, a very preliminary medical examination that you have to undergo before entering the course. But at that time, there was no psychological assessment. Over the years, what has happened, what we have seen and what we have faced is a lot of psychological issues, a lot of suicides in the course in bigger institutes. That has almost forced the authority to start this kind of program, that why not we do a psychological assessment also in the entry level along with the medical examination. I don't know about the government institutes or the institutes which are non-medical, but definitely in what I have seen in Mahatma Gandhi was there for a long time. And also what I have seen in AIMS here, we are definitely doing this, both the assessments at the entry level. Just to pick out early if there is any issue, if we can pick out. There are chances that even with a sophisticated blood tests, sometimes we miss a diagnosis. Even early, suppose carcinoma also cannot be diagnosed, right? But what is the harm if we start picking up cases early, so that if we detect out of 100, suppose we detect 5, that is also a big number, and that is also an important issue in kinds of saving a person's life, saving a person's career. All these issues will be there. So my idea is, yeah, there are a lot of shortcomings in the psychological assessment and various other things that we'll be discussing. But even if we try for at least a handful of people, then also it will be beneficial. So we'll start with the first one. I'll just give you one small quote that is a very famous one given by Steven Spielberg. The delicate balance of mentoring someone is not creating them in your own image, but giving them the opportunity to create themselves. What I feel, and it's not only for mentoring, but if a person has this kind of interaction with any person who is very close, definitely the life can change. The psychological thought process, the thinking process of a person can change. And we are dealing with students who are in their very early developmental stage. They're going to be, if you see the psychological development of Piaget, Erikson, Piaget would be appropriate, Erikson. So definitely they are in that very early developmental stage where they have to understand themselves. They have to gain that amount of maturity so they can face the world. So this is a very early phase that we can detect if there is any fault and we can rectify it. Definitely their lives will be much better. So first we start psychological assessment and entry level. This is a new thing that has come up in various medical colleges, and Mahatma Gandhi, I think, has started many years back. And we are also doing here at AIMS. This is very important to screen early mental health issues if any. This is very important assessment. And we do along with a medical assessment, a part of the medical assessment, but and it should be done in the early phase when they join the course. What we have is when they join the course, there is orientation program that we have for 10 days. Normally in every place it's like that. So in that orientation program, we try to do this as a part of the orientation program. Along with the medical, we also do the psychological assessment. But before doing that, because what Audappan was saying correctly, many students will do randomly answer and they are very bored of this long questionnaires. First, the question has to be very thoughtfully made. That is first thing. And there should be two kinds of questions that we normally do. Some are direct questions which directly ask whether you have been on any drugs in the recent past, whether there is any family issue or mental health issues in your family, whether you are anytime diagnosed with mental health issues or anytime referred to a psychiatrist or psychologist or a counselor. So these are direct questions. Some and another part is kind of what we say a kind of rating scale that we use, and we see the person's strength, the resilience, the coping abilities, the perceived stress, all these things we can see. And we select questions and we make a kind of one questionnaire that we often use is DAS, depression, anxiety, and stress scale. We take that because it has a lot of cultural variations and it has all these validations in different languages. Even a Tamil one is there, and Hindi one is also there. So this kind of scales are often used, and that is what we do to part A, part B of this psychological assessment. But before that, we cannot suddenly a bunch of students cannot say, okay, we want to see your psychological health. They will not understand one, and they will not agree also. Why? What Appan told, why you want to see our psychological health? We have crossed an exam. We have done well. That is why we are into this college. So why you are trying to see what is there? Are we having some mental health issues? So before that, a brief awareness talk is very, very important so that the students are aware what we are trying to do, what we are trying to find out, and what we are trying to deal with. So this is a very important, and I think an experienced person should give this talk with a lot of emphasis on different examples on various issues the student might face during their course. So this is a kind of awareness which will make the student understand the importance of the psychological assessment. The questions, as I told you, should be validated and easy for the student to answer. It should not be very complicated. If you directly pull out questions from a kind of foreign source, and there will be a lot of problems. One question I still remember in one of the psychology assessment was, it's difficult for me to wind up. I cannot wind up like that, something was there. So wind is W-I-N-D, and the student was asking me, sir, what is this wind? Wind up is, what is that? I am not able to understand. So it becomes very difficult if you try directly pull out questions from a kind of foreign source, but you have to see whether you can validate questionnaire is there, or you can validate a questionnaire and use that. So that is what you should think and do. Confidentiality should be maintained. I mean, questionnaires should not be discussed in open. Okay, you have written this, what do you mean by this, or what is this? Okay, what do you think? Should not discuss. And the questionnaires also should not be discussed. It's not an MCQ that we discuss the answers after that. There can be different answers. Whatever the student feels, the answers can be different. So this confidentiality has to be maintained and answers should not be discussed. However, you need to clarify all the doubts that they have. So during the session, when they are filling up, normally what we do, we give a Google form to them, and in the mobile it comes, in the mail or in the WhatsApp group, and they open the Google form and fill up. Anonymity should be maintained. A number or roll number can be given, or often we don't give that also. So, and then it should be kept anonymous. Roll number is, I think, important because then we can find out who is having what problems. So in that sense, we can do that in this manner. And the last thing that we tell them repeatedly is honest answers to be expected. Means you please read and give whatever you feel, but don't give false answers, don't give random answers. So this kind of awareness should be given to them. Then only they can understand the importance of this, and then they can answer the questions. It should not be too long a questionnaire, like 50, 60 questions, and they feel very bored answering all these questions. So this is what I think should be done, but very thoughtfully done. And a team of people should sit together and try to make this questionnaire. Now, this is what we have in our institute. And the first part is informed consent. This is another very important thing, because if you have a consent, if you don't take a consent of a psychological assessment, because the students are almost adult, and the informed consent is very, very important. What we have written here, this examination involves psychiatric and psychological assessment. Anonymity and confidentiality of your response will be maintained. Confidentiality might be breached under specific circumstances, like upon assessment, if the risk of harm to self or others is found high, or if a competent authority instructs for it. I have no objection undergoing the assessment. Then they start the questionnaire. So this kind of consent form should be there. And this is the link that will take you directly to the questionnaire. So I will share the link. I don't know whether you can see here or I can do it from there, but definitely I will share the link and you can see what kind of assessments we are doing. Next is the awareness program. The awareness program that we do, like it's not one way. Like we did a awareness program in the initial part, and then we did this assessment, and then we disappeared. It's not like that. We should do this awareness program done periodically. Means a team should be there. Normally we say a student welfare committee or a team should be there who will continue doing this awareness program with the students just to reduce the stigma, and to tell them what are the symptoms of impaired mental health. Because any course which is 3 or 4 years long, initially there will be a lot of problems. Middle time there could be some other problems, and the end part there can be some other issues. So over the years the issues will change, and the student can get into the trap, into a problem anytime in the whole 3 years or 4 years or 5 years course. So it's not that the initial phase only there will be problem. Initial phase, when we're detecting, that's a baseline. But after baseline, we should see what happens. So awareness program can be done periodically. Also, there are some institutes which does this assessment again periodically, maybe after a year or so, to see what has happened, any change in the behavior, any new thing that has happened. So our focus on the awareness program should be on reduction of stigma. So we should tell the students that this mental health issues is like a physical issue. However, there will be a lot of resistance. But if you have this, please come out, please discuss with whatever resources that you have, like a student counselor or a mentor-mentee or kind of a psychiatrist, psychologist. So these all things has to be discussed with the students. Symptoms of impaired mental health, we should tell them. They might not be aware of what is mental health, impaired mental health. They might think this is a kind of stress, or exam-related stress, or some relationship problem that is causing stress. They might not understand, actually they're landing in a depression. So we have to tell them what are the signs and symptoms of impaired mental health. Then we have to give them health promoting behaviors, like suppose stay away from substance, maintain a healthy lifestyle, right? And do a lot of activities, talk to people, interact with others. So these all things keep yourself fit. And the institute also should have this kind of facilities. If you say, look, keep yourself fit and you don't have a playground or don't have a gym, so that makes no sense. So you have to provide facilities for the student to interact, maybe clubs, cultural programs. All these things should be a part and parcel of institute. So these all things will make the program much more beneficial to them. Positive mental health, talking about positive mental health, giving them life skills training about coping strategies. So all these kinds of program, the awareness programs can go hand in hand over the years in this kind of with the students. So this a team should be there, a student welfare association or committee should be there who will be doing all these programs. Now I will discuss briefly about the mentor-mentee system. This is a very, very important system because students initially doesn't know where to go if they have an issue. So the first person of contact can be a mentor. So a dedicated mentor-mentee system should be constituted. The student welfare team will have to constitute the student mentor-mentee system and has to disseminate to both the mentor and the mentee. Maximum what we do, 4 to 5 mentee to be allotted per mentor. It should not be 20 mentee you have now, you deal. You cannot do justice to any one of them. And the mentee selection to mentor should be pre-planned. Now, what we see in the first years when the students are close with the first year's faculty and you give a mentor to the fifth year faculty, they might not know who is that. So there will be a lot of issues to contact that person, and his time, that time is totally different. So what a kind of idea is, like, two kinds of things can be done. One is you keep a stable mentor throughout the course. Another thing is that a mentor can be changed with the years, with the different courses, different subjects, so that it can be continued like that. So these all things are kind of administrative decision by the team. So these all things can be planned. The main idea is the mentee should be very connected to the mentor, and there should be an opportunity to interact. Awareness program for mentor and mentee to be conducted. This is very important. What we should do, we should know, we should tell the mentee how to how to do the, how to go about with this program. Also, the mentor has to be also told, because many of the mentors doesn't know about mental health, doesn't have an idea how to deal with, suppose there's an issue. They might say, okay, just ignore this problem. Don't think of this. You are here for to do study. Why you are thinking about your family issues here? Like that. So this kind of things won't work. So they also has to be given a lot of awareness, ideas how to deal with students who are in distress. And very important is dedicated day or time to be given for the mentor-mentee interaction. Normally what we see, if you start a program and say, okay, you have 5 mentee and you have to interact with them. Normally they don't find time. Many people are very busy. They don't find time. And they don't know when to meet. One student is coming this time, another student is coming. Like that, it might happen one or twice, then it goes away, fades away. Normally mentor-mentee system, continuing of a mentor-mentee system, what I have seen in various institutes is very difficult, fades away. So dedicated day or time should be given, a logbook should be there where the mentor and mentee signs, and that is an important aspect. Periodic report to be taken from mentor, that is important. Both mentor and mentee should give a report to the higher authorities or to the student welfare committee that what has happened, how many cases he has seen, students he has talked to, interacted, and what has happened. So a report should be there, which can be a Google form, which can be given to a monthly Google form can be sufficient. Also feedback to be taken from mentee. So these all things has to be done. The mentor-mentee system won't work. So this is, we have a mentor-mentee brochure in AIIMS Kalyani. I can share the link and Vimal can show you. So we have a very structured program. I think Mahatma Gandhi also, and we have all these details are written, and mentor-mentee awareness program happens. The mentor and mentee, what we have at AIIMS Kalyani, we have here a concept of super mentor. What we have seen that the mentor doesn't know what to do after they get some issues. So we have senior professors who became kept as super mentors. So the super mentors are kind of a grandfather, where the mentor is a kind of father. Have discuss in a closed group what is happening and discuss how to deal with all these issues. Regular scheduled meeting of all mentors with the respective mentees is done here. And there is a monthly mentor-mentee meeting that we follow in the logbook. Yearly orientation and sensation program for both faculty and for all batches of the students are done, right? So this yearly program, sensitization program, is also done. We have a manual and a guideline book where everything is written, how to do, what are the strategies that you can follow. So we encourage the faculty and the mentee to read the manual book. We also have a mentorship card. So it's like the logbook that we have, the card like a library card where they sign and has to be shown to the admin. Reminder mail from mentor-mentee cell comes before the mentor-mentee program that you have a mentor-mentee interaction. So the mentor will come and discuss things with them. The mentors will submit the report of the monthly meeting to the super mentor. The super mentor will meet with the mentor when needed. So this is what happens. The super mentor will give quarterly feedback to the mentor-mentee cell, the students' welfare committee, keeping in loop to the dean academics and the associate dean academics. Like that, it happens here. So there can be various other systems. What I'm trying to emphasize, somebody's above you, a mentor, and so that gives much more kind of, the program become more structured. Then you don't have what to do and how to discuss these issues to whom. A report of the monthly mentor-mentee meeting. The individual mentors will submit a report of the monthly mentor-mentee meeting on or before the last working
So, sir, your, your connection is lost, sir. Hello. Sorry for the delay, sir. There was a connectivity issues there, so we are trying to rectify. Probably will join in 2 minutes. Dr. Sarkar sir will join in 2 minutes. So please wait.
sorry, there was some internet issue. Am I audible now?
Yes, sir, you are audible.
Please allow me to share the
Yeah, yes. Sir.
You have disabled me.
Yes, sir. Now you can share, sir.
Right. Is it visible now?
Yes, sir.
Okay, right. I'll start. Sorry for the technical problem here. So this is how we do this mentor-mentee program, and support provided for mentors. This is a very important thing. How we do what we do. First step for identifying a student in need with psychological issues and providing support will be ensured by the mentors. And the second step by a student counselor at the wellness center. So these are the steps normally what we follow is the mentors followed by mentor-mentee will pick up case if there is, and then they will be referring to if they
Sir, your voice is not audible, sir. Sarkar, sir, your voice is not audible.
right, it's okay.
Yes, sir. If it is any network issues, now you can switch off your video, sir, and then present.
No,
Same
it's
screen.
now it's okay. I
Yeah.
think they have switched it off and restarted. So
Okay,
I was emphasizing on this mentor-mentee system because it is a very effective source for early detection, more than what we do as an entry-level psychological assessment, because that time is an only entry level. There can be no problems at all. But this is what we can detect, and many students have issues in the first year or second year. So then this mentor-mentee system becomes very, very effective. So the mentor should be a professional role model, very empathetic, willing to share things, knowledge, skills, and expertise should be there, responsible and caring, enthusiastic and optimistic, and he should be towards education, training, and personal development, towards life in general, resourceful, helpful, and kind. So these are the things that we should have a mentor. Being a mentor is not very easy. That is why we give a lot of awareness programs, how to be an effective mentor. What are the agendas that normally a mentor-mentee system should look at? Is student perceived issues, academic performance, professionalism, career planning, personal, social, psychological issues, personal, professional balance, research, scholarship, extracurricular activities, health and medical concern should be a part of the mentor-mentee system. Not only is academic problems or other, there are a lot of other things that can be. Mentor is like a parent, but it's not a parent. That's also there. So what should not be done in a mentor-mentee system is don't think that bonding happens immediately. It's a gradual process. So you should be, even the first 2 visits, you see the student is not opening up, he's coming and saying everything is okay and no problem. But slowly it will happen when you understand there is something and it's there to talk to, somebody is there to discuss to. Then don't be too authoritative or bossy. Don't be too judgmental or opinionated. That is what we do normally. We see students are just juniors. Now we can be too opinionated or judgmental or authoritative. That should not be there. Don't be just a substitute for the mentee's parents and try to do extra thing beyond boundaries. That is also not there. Don't be too accommodating. Set boundaries and priorities has to be there. Don't encroach into mentee's personal space. Don't violate confidentiality. Don't do personal favors to mentee in official exams, etc. Like, okay, I'll tell your teacher, oh, he'll pass you. Your exam is the problem. You're not able to pass, so I'll tell the teacher. So don't do this kind of things. Don't let them make habit of borrowing money or borrowing things from you. So don't be too personal in that sense. Don't take it too personal if a mentee doesn't give you advice, doesn't take your advice. This is also very important. Don't forget to take help from professional seniors when an issue is there. Don't involve your mentee in departmental or institute politics. All these things are very important because often you start discussing institute or departmental things and then the mentor-mentee system goes away. So there are a lot of do's and don'ts that you should follow. Strictly don'ts I have just made. Don't display unethical or unprofessional behavior towards mentee, considering the power difference between the two. Don't make mentee do your personal chores. Don't invite mentee to your residence or do any inappropriate advances. Don't cause harm even if they provoke you. Don't exploit them. If the situation is beyond the scope of the ability of the mentor, he or she can direct the student to super mentor. Even the mentor can be changed. It's not like that you have to keep this, even you are unable to deal with that person. So you can approach the student welfare committee. The next one is, apart from mentor mentee, another thing what I have found is very important, which can help us to early identify students in need, psychological distress. So it's a peer group program. What is that? Peers form an important part of students' life, especially when the students are staying in a hostel. They stay together, they discuss things. So peers, if you find peers, support group, if you make, who have this kind of altruistic or helping attitude, you can identify the students who have this kind of attitude and make a peer support group. So if there is any issue, early they can talk to this peer support group or the peer, rather than directly going to student wellness center or the counselor or mentor mentee. Sometimes they won't come out with that. Even peers can identify. We have seen many cases where the peers came and said, sir, my roommate for a few days I am seeing, she is not coming out of the room, she's not studying, she's crying most of the time, I think some problem has happened. So these all things can happen. A peer can help us to identify a problem early. So, and then refer the students to student wellness center. This is a very important, another very important aspect of early detection, which can be easily done in the campus, not a very structured, robust program like the mentor mentee that I was discussing too. So this can be easily done. And I think we have to identify the peers who has this kind of interest. Teacher as a mentor. This is another thing, like your mentor, if you remember your school teachers or college teachers, you might remember one or two who you are very emotionally close to or whom you liked very much. And those are the teachers, they can act as a mentor, right? Because you can easily see, because you are seeing them in the class. The mentor is not seeing you in the class. Mentor not be a part of your curriculum, your class. So a teacher under whom you are directly there, who you can directly assess that, okay, this student is having some problems. Last few days I am seeing is not up to the mark. A lot of absentees is there. He's having poor academic interest. He's not interested as before. So teacher can interact with the student one-to-one and find out the problem, right? But it is difficult for a kind of 250 batch, suppose MBBS and Mahatma Gandhi has 250 students. So if you take a class, it's very difficult, but often in a practical class, small group teaching, it can be picked up. So what is happening? Why is not coming to the class? So you can talk to them. So many a times, I think the recent incidents in IIT, what has happened, like the student was not coming in the class and nobody bothered to ask that. So it should be definitely seen why the student is not coming to class or why he's having decline in his academic performance. Those things a teacher can easily point out. Or nowadays he's looking very depressed or sad or not interested in the studies. So like that. Now, next is the role of student counselor. Now, student counselor, the problem is it's a very expert field and you have to have, like, there are a lot of counselors roaming around in the market, but I feel like a kind of student counselor should be a kind of either a part of psychiatry team or should have some kind of counseling experiences. Maybe a psychologist would be a better choice, but it's difficult to get and difficult to hire because they will, salary part also will be higher, and they won't stay only counseling the students. So either a part of psychiatry team can have a counselor or you have to appoint separately a student counselor. But one thing can be done, if a student counselor is there and he or she sits in the academic building, then the stigma of a student, that what Audappan was saying, a student is going to psychiatry department in his own college, and there's a lot of stigma related to that, and they are making fun and they are saying, oh, okay, he might be having something. So this can be reduced if the student counselor you have sits in the academic building, and the student can be easily, she can be easily approachable. That is the most important thing of a student counselor, is a part of the student. You can visit the hostel also time to time and discuss with the students. So these are the things that a student counselor can do. So it comes in between the mentor-mentee, the peer group, the teacher as a mentor, and the expert, means the psychiatrist or psychologist per se. In between comes the student counselor, plays a very, very vital, important role to understand. Even the treatment can be done at this level, and the problem can be solved by a counselor. So either it treats the usual with the using counseling skills, or can refer to higher centers, means either to psychiatry, or if the department, if the university doesn't have a kind of a psychiatrist or psychologist, can be referred to a medical college nearby. So like that, it can be a bridge in between the early detection phase and the final treatment phase. So student counselor is very, very important, and many of the institutes now, they have the student counselor. Even I think schools also, they now have counselors, right? So this is an approach, very good approach to for the promotion and prevention of mental health issues in students. And I think it's a very good step. So if the institute can hire, but you have to have the right person. That is very important. So otherwise it will be a problem. Now, finally, coming to the student salutogenesis or wellness committee, welfare committee. So this is a committee which has all this under their domain. So there should be a student salutogenesis or welfare committee, one of the key requirements of a university. So as constitutes of a senior faculty members, dean academics, dean student affair, or even you can have, what we have here is a faculty in charge of students welfare. So he's directly under the dean academics. We don't have dean students affair here. Mahatma Gandhi has dean students affair. So dean academics here is the highest one. Below that is the student welfare faculty in charge. And then they have few seniors and few junior faculties, few representatives from the students, at least 2 representatives from the students should be there. And 1 or 2 people from the outside also can be there. A counselor or a psychiatrist should be there. So like that, a team should be constituted. And there are like norms. And if you see websites of bigger universities with a higher ranking in NAC and all, they have the spread welfare and see how a student life can be better in institute. So in that sense, they will promote various activities. One of the activities will be understanding and finding out students who are in distress. Another activity can be extracurricular, student clubs, and other activities. So they deal with various issues of student life in a university. So this is what I think is a nutshell. Student welfare committee has student counseling service, student extracurricular activities. That student counseling service will have mentor-mentee, student counselor, and the student extracurricular activity, student council, student clubs, all these things, right? And there can be peer support group, alumni association, anti-ragging committee, all these things also can come and be a part of the broader part of the student service. So this is what a university should look to make and to function, so that a student can be easily identified, or a student knows where to go when he or she is having problems. Student club is very, very important. Normally what we do I have seen the website of, if you see website of SRM, there are around, I think, how many clubs will be there? 150 or 60 clubs will be there. And each club has sub-clubs like that. So at least basic few student clubs should be there. And important aspect for recreation and showcasing the student talents, it promotes positive mental health. It's very important that because the student interact, they show their talents, they have something else to do. Any issues can be discussed. Also here also you can pick out if there is some problem in some student and can be taken to the higher level. Give a chance to interact with others. So early identification also can be done through the student club and student house. Finally, we come to this team psychiatry. Team psychiatry is the final stone, what I feel. Students should not directly come to psychiatry unless the issue is very serious. It should be done at various level, because definitely students are very vulnerable population. They're very fragile in that sense. Their mental maturity is much less. So psychiatry should be there when more serious issues are there, like substance, suicidal ideas, self-harm behavior, all these things. Things which are milder can be sought out at the mentor-mentee level, the peer group level, teacher level, or the student counselor level. That is what I feel should be there in the salutogenesis. So team psychiatry should see referred cases. However, often directly cases also comes to the psychiatry department. When, however, it shows the lack of the mentor-mentee or the student counselor services. But if somebody feels that the psychiatrists are best to deal with psychological issues, then they will directly come to psychiatry department. Appropriate treatment is given considering the biopsychosocial approach. That is what we do. We don't only give prescriptions of medicines, not pill pushing. We try to see the whole patient as a whole, the person as a whole, and we try to deal with the psychological or social aspects. Those are very important in the student life when they have this kind of issues. There will be very less person who has directly, you can say, severe mental illness, suffering from severe mental illness. They have issues mostly related to their relationship, their studies, because of their adjustment issues, and because of the course, all these things are there, or even the peers. However, a student may approach the department directly or maybe referred from SWC. Confidentiality to be maintained and information to the top to be given, all concerned. This is very important, confidentiality, because when a person comes to the department of psychiatry, then definitely we have to, what Audappan was saying, we have to inform various persons. Like we have to inform the dean, we have to inform the student welfare committee, we have to inform the parents. So the confidentiality then becomes breached. So that is what is the issue, that we have to, how to deal with all these things. We have to discuss with the students. Like, this is like slightly more kind of a problem. Now we have to inform your parent, and we have to inform the teachers. So this is what the protocol is, has to be very clearly told. So, however, there can be hindrance to that. They might not come back to you again, or most of the time their guardian will come and take them to their own native place and get themselves treated. But still, since these are protocols, has to be maintained. So I think has to be done, but in a very soft manner, in a very kind of discussion, in a kind of discussion you have to enter with the guardian or the student, then only we can do. Now, there are tools of mentoring, and this one tool that we use here is a MINT tool, mentoring styles, and there are a lot of details. So I can share this. You see what is your mentoring style, whether you are able to mentor. In that tool, there are different styles of mentoring. One is letting go style. Okay, whatever you want, you do, but more or less manage your life. Active listening style, you listen more than to give advice. Another is advisory style, you try to give advice more as a mentor. Another is prescribing style, you try to prescribe, okay, this you can do, this, that you can do, like that. Cooperative style, I think this is one is very important. You try to cooperate and you try to understand. So this is what are the different mentoring styles. Now, the Student Welfare Committee at AIIMS Kalyani, what we have is a separate committee headed by faculty in charge of students' welfare, and is directly under Dean Academics, what I was telling you. And we do a psychological assessment by the Department of Psychiatry at the entry level. That is what we do along with a medical examination. And we keep the report confidential and we hand over to the Student Welfare Committee. And here is a very organized mentor-mentee system in place with introduction of super mentors. And students' houses are also in place. So they have a lot of student houses, student clubs like that, which have interaction. Team psychiatry is very active, and as faculty, we have a faculty dedicated to handle student problems, student issues with a psychologist and psychiatric social worker. So this is how we manage from our side, the Student Welfare Committee at AIIMS Kalyani. And the anti-ragging and student grievance cell is also present. Like students also has to given some chance to discuss. A feedback form is there. I told you the mentor-mentee system is a robust feedback form. There's a students grievance cell where they can post their grievances, and the things can be seen by the Student Welfare Committee. Now, Dr. Vimal. Hello.
Yes, sir.
Shall I share one or two case vignettes before?
Yes, sir.
Right. So these are the case vignettes. I have two of them. I will just show, and maybe one or two people can have a discussion. Recently, a student was referred to psychiatry department.
Sir, just a minute, sir. I request Dr. Audippan sir to just give a word about the WhatsApp polling, as he is going for another meeting now.
Right.
After finishing, shall we have a case vignette, sir?
Right. No problem.
Okay. I request Dr. Audipinsa to.
Sorry to disturb you, sir. There's another meeting just at the
Right.
time.
Right. Okay.
Can you put up the questions, please?
So I stop sharing the screen.
Yes, sir, please.
Ah.
So I will just, then I'll read the question one by one and then I'll try to answer, sir. Your opinion is also warranted, sir.
Right.
The first question is, a scale to screen for mental health problems among students should have the following attributes, except A, it should be reliable and valid. It should be able to detect all mental illness that can occur in an individual. It should screen for protecting factor in the individual. It should be linguistically and culturally valid. So the scale should be reliable and valid. That goes without saying. And
Right.
it should be able to detect all the mental illness that can occur in an individual. That is not actually necessary for any screening tool. The objective of the screening tool should be to see the major mental illnesses or common mental disorders, as we call, and these should be screened, and they should be able to pick up these issues. Also, not only ruling out mental illness is a part of early screening, picking up protective factors which can prevent the illness from occurring is also a major important issue. So that should be incorporated into the scale. And as I told earlier, it should be culturally and linguistically validated. Your input.
Right. Yeah, I also do agree that it should also have this positive factor. It's a very important part what you have picked out. Like what we try to do in a screening tool when we are doing assessment, we go to that medical model and think that how many kind of pathologies we can dig out of a test. So it's not like that. We should also have something positive in a test so that students are also interested, and we can find out the positive aspect of the student too. That might help. When the student, suppose in future, goes into a kind of psychological distress, we can use these attributes for his or her management too. So this is a very important part, and definitely all mental illness cannot be screened like that.
Okay, sir. And the second question is, all are possible danger signs of stress except sleep disturbance, overeating, excessive tearfulness, feeling confident. Usually stress occurs, we have discussed that earlier also, stress occurs whenever the individual feels overwhelmed above his coping resources. So when the individual feels overwhelmed, rarely they can feel confident. So obviously that stands out. But the other things are also very important. We need to be very careful of these danger signs. Sleep disturbance is one of the major issues. But the problem with the current generation is with their sleep hygiene. Most of them are into binge watching and nighttime study routines. All those things are impairing the sleep hygiene of the students. So those factors should be taken into account. But if there is a consistent decline in the sleeping pattern, that should be immediately noticed. And then overeating is again an epidemic, especially stress eating, stress binge eating. All these things are very important things. And excessive tearfulness is another, or excessive emotionality. That is another issue that we can see in the individual. Your comments, sir?
Right. I think very nicely told now, Depan, that the initial signs of stress has to be understood. And if there is a sudden change, that is what we often say, that the student was otherwise sleeping well, eating well, and then suddenly over last 1 or 2 weeks, it started showing that he's not able to sleep, or he's sleeping more, even in missing his classes, morning classes, because he was sleeping, or he's eating excessively, whatever change in biological functions is there. These are the early signs of stress. And if that is not taken care, then the stress becomes more and more and leads to us mental illness. Often we see it ends up with depression or anxiety, and then it becomes difficult to treat. So the students has to be very aware, like what I have told in the awareness programs. What are the early signs of mental ill health when you are not totally mentally ill, but when you are in that journey, I think in that road. So whether we can detect early and stop at that level. Otherwise, you will end up in a very serious issue, and that will be detrimental to your career, your other things. Often we see students are not coming in class, and when we ask why you're not coming, then somebody says that, sir, I couldn't wake up in the morning. Normally, other students would laugh and say, sir, whole night he's watching movies or he's playing games. That is why he's not waking up. But we have to, as a mentor, as a teacher, we have to maybe separately ask the student, what is happening to you? Is it like a recent occurrence, or is it now? Maybe at times it can happen with the stress. Student is not sleeping, he's playing his games just to get rid of the stress or anxiety, upcoming exam stress. So it can happen. So we have to be more aware. As a psychiatrist, me and Audeppan can understand these things, but as a non-psychiatrist, many of our friends are here who are in different institutes. So I think they have to be given this kind of training so that they're aware what are the early signs of stress and which to pick up and which not to pick up. That is the most important thing.
Moving on to the next question. Mental illness is caused by following except chemical imbalance in brain, familial conflict, past mild head injury, social isolation. This question was primarily put up because there might be some misunderstanding among the attendees about the causation of mental illness. So just to get a chance to explain the causation of mental illness, we have put up this question. The causation of mental illness now we have is the biopsychosocial model. The biological component of that biopsychosocial model is the chemical imbalances, which are the end result of a multiple and complex things which have happened from the development.
No, that's the complaint has always been there.
So the next thing is support, psychological resistance or psychological the psychological makeup of the individual, which is very important. And then there comes the social support which the individual has. So all this put together play a role in the causation of mental illness. But the past mild head injury, this option was put up because one of the most common reasons people tend to attribute is because the head injury is something which people don't forget, and they used to say that the last 10 years ago they had a head injury, so is that the reason why he is having this? And mostly we have to understand that unless until it is a very severe head injury and which is associated with multiple loss of consciousness and other things, they don't actually directly cause mental illness. So we need to be worrying about a lot of supplementary factors like psychosocial factors rather than about the head injury. So that's a reason to explain that we have put up this question to you, sir.
Yes, there are a lot of causes of mental illness. Often it is a multi-dimensional cause, means multiple things add together and cause mental health issues. In students, what we commonly see is chemical imbalance and all. They will not understand because they're not seeing what is happening inside the brain. But definitely when there are psychosocial issues, when there are relationship problems, when there are problems with family, definitely they'll end up with having stress, they'll end up with having mental illness. So these things are to be understood, that psychosocial issues plays a very, very important role in the occurrence of mental health problems or issues in student life. So we have to understand that, and we have to make them aware of this.
Okay, moving on to the next question. What is the best way to follow up the students in need of psychological help? Ask them to visit psychiatric OPD, phone counseling only, a separate student counseling center in the institute, student to seek help from their native place. I think Sarkar sir has discussed in depth about this in the setting of the consultation is also very vital importance. We cannot directly call them to Department of Psychiatry. So we need to have a place in the hostel or in the college where there is a confidential and the students can seek help. This is a very well established practice in all Western countries. In the Western countries, schools and colleges, they have professional counselors, student counselors, and the student counselors will screen, pick up early issues, all the academic issues, and they have the power to call the student to their counseling rooms and do the counseling themselves. And if in need of, if they identify any high risk issues, then immediately they'll refer them to the competent authorities. So all that is streamlined. We need such a streamlining here. So the answer should be like a separate student counseling center in the institute. So we need to strive to establish our institutes in all these institutes. Over to you, sir.
Right. As I have told in my presentation, a student counseling center or wellness center is one which is the need of the hour for every university, and to detect early, to not only detect psychopathology, but to give them wellness also, to give them a chance to understand their potentials, to give them a chance to be more creative, more experimental. So all these things a student wellness center can give. So if we just if we try to understand a student, so this kind of center should be there where the student can approach. They, under them, the student counselors will be there. Now, psychiatry, definitely there will be a lot of stigma if a student is directly coming, referring, what you have mentioned and what you have seen also. And definitely when the things are more serious, when the things are cannot be solved at that point of time, definitely a psychiatrist help is often needed. Often the student welfare wellness center has a psychiatrist or a psychologist attached to that. So they also can see. So definitely the correct answer will be student wellness center.
Last question. When a student expresses death wishes, what should you do immediately? Talk to the student and know about the extent of the suicidal idea and plan. Refer to a psychiatrist or psychologist. Advise them about need to live and convince them to drop the idea. Call the parents. The most of the answers which I have seen picked refer to psychiatrist or psychologist. Actually, the point here is immediately. So whenever someone expresses the death wishes or something like an I want to die, or why I'm living, all those ideas, when they express, the very first thing we need to understand is they have expressed to us because they are in a dire need for talk. Most often that immediate intervention, that that talking with the individual, setting some time for them to talk with them, that would solve the crisis. But if we refer them to psychiatrist or psychologist, that referral might happen or might not happen. So if it fails to happen, then the individual might we might miss a golden opportunity. So that is why the best option would be to talk to the student and know about the extent of plan. And again, once we know the extent of student's idea and the plan, then we can take preventive measures. We will need to know how much panic we have to raise, or how much big the call for help should be. If there is a very acute, immediate need for intervention, then we have to take it to the proper authority. Sometimes there have been instances where the student should have to be kept in the direct observation, and then only when the competent responsible person comes, then they can be let to go. So all that we had to do in some cases. So those are the things which we need to do. That happens, the very first step starts with the talking to the student. So over to you, sir.
Right. What we see in a heart attack, we have this concept of a golden hour that we have when we talk about heart attack. A golden hour means the initial few hours, that is very, very important. Whoever, like a basic knowledge about psychiatry, or even a good person, if you talk to that person, then you see the half of your things comes down, because suicidal thought is very impulsive thought. So I remember WHO had one kind of slogan in one of the World Mental Health Day, that give 10 minutes to save a life. So they say if a person expresses, and if you come to know that he is expressing suicidal thoughts, suicidal ideas, expressed to kill himself or herself, please sit down with the person and talk for 10 minutes. That will save his life. You might generate much more solution than the person has, because the person is in severe distress. He might not having any kind of solutions to his problems. So as an outsider, you are listening to his problem. First, you have to listen. You don't have to jump and say, oh, okay, understood, or don't ignore this. Don't give this kind of judgmental comments and all. first is to listen. Maybe you give 10 minutes to listen, and then you can propose some of the suggestions that is there. But even if you feel that he is very, very disturbed, then definitely the next part is there, refer to an appropriate person. Maybe you have to refer to the student welfare committee, and they will refer to a psychiatrist. That is what is a normal routine. But definitely the answer should be you sit and talk. Don't waste this golden hour to save a life. That is very, very important.
Thank you for your reply, sir. And I take my leave. I think you can continue with the vignettes.
Yeah. I just show, thank you, Audappan. It was nice interacting with you. And all the best for what you're having now.
Thank you, sir.
Right. So I will just show this because I'm seeing a chat. You have to finish first also, because this is it's a recent onset thing. See, a student was referred to psychiatry department. What happened recently, a student came and was referred by a medicine assistant professor, saying that during the medicine posting, the student got sudden tremulousness and severe anxiety and started crying. They were seeing a case where the patient had history of it's a carcinoma in the maybe in the early stage or mid stage, and there is some metastasis and in the brain and all. So that case was being discussed, and maybe the medicine professor told that the chance of survival is less in this case, maybe 1 year or so, but we'll try with this medicines like that. So the student suddenly started having tremulousness and severe anxiety, kind of panic-like attacks, and started crying. So the medicine person thought like it's a case of mental problem. So immediately we were next door. So they brought the student. When I saw the student, she was she's a female student. She was tremulous. She's very frozen, and she was not able to speak, and she was also crying. And it looks very odd, like why seeing a case where kind of death is being discussed and she starts crying. And when we asked, it's not the first time she's seeing a case. There are a lot of cases she has seen. She has been posted for last 3 months in medicine, and the student didn't have such prior episodes. So when I asked about the family, the psychosocial issues, that is what we see in such a case, that she's a single child and was very bright in her studies and comes from the western part of India. She's from Maharashtra. And we thought, okay, maybe because of her distance from this place, she's unable to adjust. But it's 2 or 3 years she's there. She has passed her first professional. It's the second prof that she's into. And then on probing again, and why this, when we asked what made you feel so tremulous and what made you feel so disturbed, we gave a deep breathing exercise to this student, and after some time she calmed down, and she told like hearing this death reminded of the death of her grandfather. So when we asked, her grandfather died 1 year back, with whom she was very close. Grandfather also had a kind of similar kind of history, was diagnosed with carcinoma, and he finally succumbed to his illness. So this kind of thing, the student might not be able to get out of the grief of the grandfather. However, she was doing a lot of things, and this kind of case have precipitated that reaction. This is very common in grief. We get this kind of thing known as anniversary reaction, or a kind of grief reaction suddenly on various occasions. So in this case, what we felt, it's not like we have to aggressively treat this student with in the psychiatry department and all. We just gave a deep breathing and we said, these are normal things. This is not very problematic. Okay, right, your grandfather thing has definitely affected that. But whenever you are having this, you do some deep breathing exercise. You can come for later counseling sessions and all. So this student was referred back to the medicine, and now I have seen her few days now. She is enjoying her posting and all. So there can be cases which suddenly looks very challenging, but it finally comes out to not very difficult thing to be managed. Another case vignette is there. A student attending the psychiatry class on depression wanted to speak to the faculty who took the class. So there was a class on depression, and the student attending that class came out behind and asked me. I was taking the class from back. She asked me, "Sir, I want to talk to you." So I thought she was having some doubts regarding the class that we have discussed. So I waited there and stopped there and said, yes, tell me. Then she told that she's having this kind of similar symptoms for the last few weeks, but ignored, thinking that it can be related to upcoming exam stress. So she was having this kind of symptoms of depression, what we have discussed in the class. And then she was ignoring it. And she was not also coming out because she doesn't know where to go, what to do. When she saw discussing, she thought maybe I can help her. So I called her in our department and we had an interview. And what I have found that not in the department, I called in the admin separately so that there is no other problems, no other issues of stigma and all, that she is having prominent depressive symptoms which precipitated after poor results in the mock exams. There are some pre-MBBS professional exams and all, sent up exams, what we say. So before, and she had very poor results and she thought that she's going to fail in the upcoming exams. And that is what precipitated her kind of depressive symptoms. She also had this kind of episode in the past 1 or 2 times in a school. So she was not able to concentrate and there was disturbed sleep and appetite. So this case needs some amount of counseling, or if needed, some amount of medication to relieve her from this kind of stress or kind of psychological distress that she's encountering. Right. So this is another case where we can just wait, talk to her, understand what is happening, right? Because she had these symptoms, but she was ignorant and she didn't find where to go. Most of students have this kind of issues. So I think with these 2 case vignettes, we can understand that there is a vast heterogeneity of students having different issues, right? So we have to understand that rather than be very judgmental, we have to talk to them, discuss the issues, and maybe with various systems in place, we can definitely pick out some of the students who are having problems. Thank you. Any questions? I'm free to discuss for 5-10 minutes.
Thank you, sir. Such a wonderful presentation, sir. So we have a few queries, sir. So the participants are open for the queries. Dr. Jeffrin sir has asked, is there any paid or free courses recommended for being a better equipped mentor, as most of us feel inadequate in counseling students in need? Is there any free or paid course in the mentor-mentee?
I am not aware, Dr. Jeffrin, but definitely I will look around it. What I have seen, what we do, because we take the help of the Department of Psychiatry, and we have also been into that to design that mentor-mentee brochure book. I think I will give that book to Vimal. You can circulate. And course, I don't know. Maybe now, because those things are very important, and being a good mentor is very important. Understanding what your roles and responsibilities of a mentor. Not that you're a mentor. Okay, you're a student, by default also you're a mentor. Sorry, you're a teacher, by default you're a mentor. So by default, if you're a mentor, you are not interested in that. You might not be interested in the students. And you might ignore the problems and say, just ignore this. Okay, focus on your studies. What your parents have sent you. Like those questions you will ask, and the person who's having an issue, a real issue, might not get benefited with that, right? So I think this is a very good thing that you have asked. Maybe I have to also see whether there are courses recommended for being a good mentor, or training of mentors can be there. Many institutes have this training for mentors, mentees. We also have an awareness program, and medical education unit often does this thing with the student welfare, training for mentorship and all. They are doing this. So I think you can see any place where this kind of training is being done.
Thank you, sir. Participants, if it is any queries, you can post to chat box or you can ask sir directly.
Sir, good afternoon, sir. This is
Yeah, good
Dr.
afternoon.
Padmavati here, sir. How
Yes,
are you,
madam.
sir?
Fine.
Sir, I have a question. We are doing the analysis, the assessment at the start of the course. Do you think there will be an impact of they are coming just after the NEET entrance and their exams? Will that impact the questionnaire analysis, sir?
Right, definitely. That if you do a questionnaire at the baseline, that is, I only felt that is only a baseline assessment if they are having some issues. But since you are doing when they are coming to the course, they have not started the course yet. So it should have been better done at least a month or so, or 3 months after they started the course. Then only you will find what are their issues. Are there any adjustment problems? Somebody is coping better or not? initial, when we do the medical, we are doing along with that, it might not provide much of information because they are slightly stressed. They are coming out from their home. They are staying in a new place. If there is a cultural difference, definitely there are some other issues, language issues, culture issues. Then suddenly it will be stressful. So the results might be biased in that sense. So I think better if you do that test after 3 months rather than at the initial entry level, when they might not understand also these things. So that is why they give random answers and the results are not, when the analysis is not done correctly. What we can is initial 1 or 2 months, we can give them some awareness talk, some awareness program regarding mental health, the life of a student. You can explain what will happen throughout the course, and what are the things that we see with examples and all. Then I think we can give them this questionnaire so that we can correctly find out who are at risk. We are here only to find out who are at risk. And they can directly approach some students at risk in the after. I have seen after answering their question, they come to us and say that I felt this, these are the things that we are having. Can we have a kind of a support group, or can we help? Can you help us? So better to do it after 2 or 3 months, after a good awareness talk. That is what I feel. But now most of the places we do with the medical examination, the entry level only.
Thank you, sir. So one more question relevant to that. Do you have to do the assessment every year, or there is any time period to do the assessment?
Yeah, there is no time period, but what we have started here is like what we have seen. If you do once, and then the stress or whatever experience of life what they will have throughout the course, then that will definitely have a effect on their mental health. So if you are not assessing them anytime, only the initial assessment is there. On that basis, it's very difficult to find out what is happening to the trajectory. You won't find the trajectory. Maybe you can devise not the same tool that you have used, but a kind of different tool for yearly basis assessment, at least after each, suppose in MBBS, after each professional exam or before each professional exam, you can do an assessment and see how they do, how they will do in the upcoming exams, or at this point of time after 1.5 years, 2 years, what is their mental health status. So yearly assessment is definitely needed, but it has to plan. Is it yearly with the same tool or a different tool, maybe a brief version of that, because the same tool, if you use, they know the answers. Normally what we do, we don't do that same tool for student population or a person who is not having any mental illness. We don't repeat the same thing. They will know the answers and they will tick the same thing. So you have to design something else. Maybe in an MBBS course, I think thrice you can do the test at the initial level after 2 or 3 months. Then maybe after 2 years, around 2-year level once, and then around after the 4th year or like that, when they're in the initial phase. So you can do thrice a test, and that will be beneficial. But you have to, those things need a lot of effort. You have to design such tests, and then and it will make the thing more unique, the program more unique.
Thank you, sir. Thank you for your explanation, sir.
Thank you, sir. Any other queries?
Sir, I have a question, sir.
Yeah, definitely.
Sir, you said that before we do this screening process, we have to take informed consent from the student. So what do we do if there is a student who refuses the consent?
Yes,
Doesn't sign the consent?
Yeah, definitely. This is a very important thing. We cannot force them to do this kind of psychological test, because if they ask you, means it's not a medical test. That medical test, the thing is there, at least you can say, okay, we are trying to find out, and there are cutoffs for everything. Here, there is no cutoff. So what can be done is like, I told you, before administration of this test, you have to have a good awareness talk, a discussion why we are doing this test. Unless you discuss this thing, what are the importance of mental health in a student's life, and what we are going to do with this test. Are we going to give them a marks? Are we going to say that so many students are below par in their mental health, so we'll directly refer to counselors? They have a lot of fear and all. That is why they might not be willing to do a test. So those things has to be discussed with them, that this confidentiality has to be maintained. We will not discuss the results. If we find some issues, we can direct call you one by one and discuss. We have this kind of facilities in our institute or university. So after discussing, you will see if you suddenly give a test, 50% will have not give consent. But if you discuss all these things and do the test, maybe it will boil down to maybe 5 or 6 people not giving a consent. Right. Now suppose the student is not giving a consent, then definitely you cannot force them. You don't have to do the test. Means you cannot give the test to them, because psychiatric test needs that consent. What you can do, you don't force them. You don't try to manipulate them. No, you have to give, otherwise these all things will happen. You don't talk, let them go. You can talk to them separately, and maybe you can administer later at a later time if required. So that is what many students have, this personality issues also. We don't forget that they have this antisocial personality. They have this conduct like problem. They might be rebellious. They might say, okay, you are doing this test, you do, I'll not give. So those things are also there. So we have to see why they are not giving that. You can talk to them separately in a closed group. What is happening? Why you are not given the test? What do you think? What is the reason? You have to ask them. But definitely, if they have not given a consent, you cannot take the test.
Sir, other than the depression and anxiety scale, are there any other screening tools we can use?
What we normally see is depression, anxiety, and stress. That is what we try to find out. However, there are positive components also that we can see is the coping, right? There are a lot of coping strategies. What coping strategies does they use when they're in a difficult situation? Because the college life, there can be various difficult situations. So we can see, okay, what kind of coping are they using? Mature coping? Are they using immature coping? Are they using faulty coping? Those things can be found out. So that depends on the various life circumstances that they face throughout their life in difficult situation. Many people, when they face difficult situation, they try to run away from that. They don't try to face that, right? That is their way of coping, right? So that will be very faulty. So in the questionnaire, coping is one. Another thing that we see is resilience. What is their strength? How much stronger they are to face the adversities of life? Because those things will come. So resilience, coping, then mental health well-being is another thing that we can see. There are scales for mental health well-being. So there are two aspects, what I've told you. Na? One is a kind of pathology part where we try to see depression, anxiety, stress. And one is the positive part aspect of mental health. We see the person's attributes or the positive side of the person. Those parts can be used later when the person is in distress, or those parts can be used when in various other activities, right? So that part also we should see. And some questions can be direct questions where we directly ask that whether you have been to a psychiatrist, whether you are on medication. They go, what I remember one student here had totally hidden that he was taking medicines for epilepsy, and he got admitted here. And after 1.5 months before his exams, there was stress. He was not sleeping in the night. He missed few of his pills, and he had a full-blown an epileptic attack. And he was admitted in a local hospital here. And there were a lot of issues why he was not picked up. So if you hide those things, then a student, you might not be able to pick up. If the test will show everything normal and you are not able to pick up. So we have included, are you on any psychiatric drugs, neurological drugs, or any other medications recently for any of your problems? So if he says yes, then definitely the student counselor, student welfare committee has to note down, okay, we have one or two students who are having epilepsy, one or two students who are having, suppose, some kind of headache, a migraine. So we have to see. Those things are also important rather than only depression, anxiety. Depression, anxiety you might not pick up, but they might have a neurological or a neuropsychiatric illness. That is important. This epilepsy case, I remember, we have to run in the night. That time our hospital didn't start. So we have, the student was referred to the state hospital, and the night at 10 o'clock, being a psychiatry head, I have to run and see the student, what has happened. He was also slightly delirious. And then his parents came, they were from North Bengal, far away. So there were a lot of issues. We have to keep some students there to stay with him, and he was not willing to stay. So a lot of problems happened. So these are the things that we have to look into, not only depression, anxiety, but various chronic illness if a student has, that also has to be seen. One of our student has hemophilia. Now we have this kind of, there is a PWD category, as you know, person with disability. So that they declare. But suppose a person has hemophilia, a blood related issue, how will you find out? Unless they declare. Tomorrow there might be a blood requirement suddenly. So how will you deal with that? That's also another issue. So thalassemia minor, if the student has, how will you know? Unless they divulge. So this medical and psychological both aspects has to be directly asked also from the student. And an honest reply is very, very important. They will feel that the course, they might be thrown out of the course if they have hemophilia or thalassemia or a kind of epilepsy. So they might feel that, and they might not divulge. But we have to, through this awareness program, during the orientation sessions, we have to discuss with them so that they come out with this.
Thank you, sir. So I think we are. Ma'am, do you have any other queries, Dr. Leena?
Sir, sir said the ideal mentor-mentee, the ideal number of students is 4 to 5. But in our setup where we have 150 students and 200 students, how to go about, sir?
It's that is why I told. Possible. Yeah, definitely. Ideal is always not achievable. That is what is there. So ideal means then the mentor can do justice with the students. Otherwise, if you have 25 students, it becomes a mini class. So you call everyone and say, hey, how are you? Everything fine, then go. Like that, it will happen. It will just be a formality rather than any robust system. So if possible, you can involve year-wise or make it slightly different, think slightly differently. So you can involve the students, right? Even there is a concept of senior student being a mentor of a junior student. Like those concepts are also there. Like support staffs are mentors. They also can be trained. Like not only faculty members, but support staffs in the department can also be mentors. So if you have a less number of faculty members, you can involve other people also. So like that, you have to think something, or year-wise you have to divide so that this, but this is very effective if you do. The early identification can be easily dealt, and the student has somebody to speak to. They might be afraid of their teacher directly to discuss things. I remember, I tell you one small story here. Here, one student was there who was from kind of Bihar or Jharkhand, and he has studied his till class 12 in Hindi medium. So he even I think in South India it happens, they study in Tamil medium, and then they have a lot of difficulty when they start studying this MBBS, which is full in English medium. So this student never had this courage to come and say to the teacher that I cannot, I don't understand most of the things because I have not studied in English medium school. So there was a lot of problems. Somehow he could understand, he could tell, but he cannot write a long essay question and all. So finally he failed. He failed in the exam. And then when in the before the supplementary, we have this kind of snacks kind of group where we pull out of students who need support or who are weak in the studies. Then this student somehow got referred to me because I was in that group also. And then when I asked him that why you are not studying, what is the problem? And he looked very anxious kind of person. Then he told me, sir, I don't understand English much better and everything is being taught here in English. So I cannot write. So I said, you have not told, you are here for 1.5 years. Well, no, I am scared of my teachers. I cannot tell them. Maybe he has tried and nobody listened. And then he kept quiet and then suddenly he avoided classes and finally failed. So these all things happen. A small instance where we can change the life of a student by talking to them, understanding. This part can a mentor-mentee system can definitely bring. Or a very good teacher who is very emotional towards a student can pick up, okay, this student is not coming, or he has never answered any question in the class. So what is his problem? Is he having some anxiety issue? Some students are very anxious. They cannot stand and raise their hand and answer, like a kind of social phobia, what we say. So it was there from his childhood. Maybe never in the school, never in the assembly he has come forward and spoken anything. And then suddenly in the class, in the Viva table, he has to speak. He gets frozen. He cannot answer. He gets very anxious. So these kind of things can be dealt at an earlier level so that this student can be rehearsed how to speak publicly. Because this is a different ball game totally from the school where the oral practicals are much lesser. There are high, the oral practicals have equal marks or even more than theory. You have been exposed to a person. You sit in front of a person and have a viva. So that kind of exposure was not there in your school. So how will you expect a person with social phobia suddenly sits and discuss all the answers? It's very difficult. So these all things can be understood if you do the psychological test after 3-4 months, or if you do this periodically assessment. Otherwise, you will not get. Anything else?
Sir, one last question, sir. In our
Right.
CBME curriculum, there is hardly time to put our syllabus itself, sir. Our course material itself. Where do we fit in extra time for these awareness talks, awareness programs?
Right. These programs are not been done by everyone. I think that's what I was trying to say. First, you should have a committee, a kind of student welfare committee. They will arrange this program. And the students in parts you can give. Like, it's a half-an-hour program. It's not like you have to give 1 or 2 hours for that program. Half an hour, a short awareness program on mental health promotion. You can even show a video. You can even show a video of mental health issues so that they identify. I told about the student, na? She was totally unaware that these are symptoms of depression. Unless you impart knowledge, because you're not teaching them psychology, you're not teaching them mental health, you're teaching, suppose, humanity, some other subjects, you're not teaching them this. They might not be aware. So somehow you have to fit, maybe a half-an-hour program, maybe a video presentation, maybe you can do it in a different form, in a seminar on mental health, like that you can do in your curriculum. So something extra you have to think of.
So thank you, sir. I think we are running out of time. So any queries can be posted in the WhatsApp. Even the resource person also in the WhatsApp group. So if it is you have any queries, please post in the WhatsApp group also. So thank you, sir. Thank you for the wonderful session. I thank Dr. Aurifan sir also for the presentation. So thank you, sir. Thank you, ma'am, for joining us. So the next session will be on next Tuesday. So thank you, everyone.
Thank you,
sir.
Vimal. Thank you,
Thank
Padma, madam. Bye.
Thank you, sir.